another wellness podcast, and I have Carla Hayes, nurse practitioner to our cardiovascular service. So we're going to talk about all things heart today.
Yay.
Thank you for coming, Carla.
Yes.
So first, let's talk about something. Heart attack. That's something everybody knows about. So when do they need to come?
So if you're ever experiencing chest pain, it's always a good idea to be checked out. That way you're not sitting at home worrying, family's not sitting at home and worrying. But if you develop chest pain, pressure in your chest, a discomfort, tightness, you really don't know sitting at home, is that from high blood pressure? Is that a blockage in the heart? Is it palpitations? Did you have an arrhythmia or something that's causing it? Or is it just stress? Until you had a couple of tests ran, we really can't tell you either. So typically, if you come into the ER, you've developed chest discomfort, some shortness of breath. Men typically will follow textbook. So if you ever look at a textbook symptoms, it's chest pain that goes to the left arm, maybe up the jaw, you get short of breath, you may be dizzy, a little nauseous, maybe sweating. Most males will present that way. Females, however, will not. We don't have time to read the textbook. We're busy taking care of everybody else usually. So our symptoms are more vague. I'm just tired. Something just doesn't feel right. And we a lot of times will just push those symptoms off. But it is important, if your body's telling you something's wrong, listen to it.
Right.
So you develop chest pain and everything, you want to get checked out, you come to the ER. The first thing that they're going to do is get an EKG on you. That's looking at the electrical part of the heart, seeing is there any kind of changes, anything that's going on. If that shows changes, what we're looking for are elevations on it. The ER doc's going to call our cardiology team, our cardiologist. They're going to send the EKG. They're like, yep, this is a heart attack. Let's get him prepped. Let's get him to the lab. The good thing about being in this facility that I so love is the fact that we blow the national standard from door to balloon time out of the water.
For real.
Our door to balloon time is phenomenal compared to the national standard. You get 90 minutes, and if you look at our times, we're from the time they hit the door to the time we have blood flow restored in the heart. Our average is usually anywhere from 36 to 45 minutes.
That's amazing.
So that's really something to brag about. Something that the whole hospital, from the ER to our cath lab to our interventional our whole cardiology team, that's something that we've excelled in, and that's a priority. We're also judged on if it's an outside facility. We get a lot of heart attacks. We've had people flown into us. Hospitals up the hill, down the road, anywhere, you get a 90-minute window, and we're still meeting under that national average. So just because we try really hard to work with the teams, pre-hospital, they're trained. If they recognize a heart attack, they call in, hey, I think this one's having a heart attack. They go ahead and notify our cardiologist. If we can send EKGs out in the field, they'll send it to our cardiologist. They'll be like, yep, so we have a team that could be potentially waiting on them from wherever they come from. And that's really important. So I always tell patients, if I'm doing education or whatever, call, get help, because it's easy to say, this is a heart attack, we need to move, and we move really quickly because that time is muscle. Whereas somebody sits at home and worries and stuff, and then 2 or 3 days later they come in, they've still had the heart attack, but now there's some damage being done that we may not be able to get back, irreversible damage. So, any concerns, come in, get checked out.
What are some other things that you all treat here at the facility?
Yeah, so not just heart attacks. We do pacemakers. We have done, we actually were the first one in this area recently to do the sub-Q ICDs, which is kind of new. We have a lot of dialysis patients, a lot of open heart patients, and those patients may get into heart failure but don't need a traditional pacemaker or an ICD, what we call a shock box. So we've been able to coordinate with other companies and stuff to be able to perform that here, where we can not mess with the chest, and we don't mess with their fistulas and stuff and everything, and still provide them the care that they need to prevent sudden cardiac arrest. So devices, pacemakers, defibrillators, all of that, loop recorders we do. We are also known for our vascular. We do a lot of peripheral, you get a clot in the artery in the leg or you get a DVT. Lots of patients, our diabetes and our renal patients, suffer probably the most with just poor blood flow overall. So we have a high number of those patients that we see. I also, our team here we do open hearts, we do valve replacements, thoracotomies, FemPops. I know that's a lot of big terminology, but anything vascular, anything with the vessels, blood flow throughout the body, we do.
We do it here.
We do it here. So that's what makes us kind of unique in this rural area is we're doing everything that some of the bigger hospitals are doing.
Yeah, we are.
And we've been doing it for years. Mm-hmm. So.
And we're good at it.
We are very good at it.
We love our patients.
Yes.
So when you mentioned like DVTs, and what are some signs and symptoms, potentials need to look out for?
Yeah. So DVT is a clot in the vein. Mm-hmm. Typically, we'll see this people who have clotting disorders, or maybe you've been sick in a hospital bed or at home. Maybe you got the flu and you spent all week in bed and you didn't move. Our blood kind of gets thick and it can cause a clot in that vein. When that occurs, a lot of times what will happen is you'll have swelling and pain in the calf. Typically, most people will see it in the calf area first. And it's what makes it unique is it's usually just one leg that's swelling versus both legs that swell. Mm-hmm. So one leg, one extremity, an arm, you can get it in the arm. Anywhere there's a vein, you can get a clot. Anywhere there's an artery, you can get a clot. So typically swelling and pain are your first indications. Mm-hmm. Versus like cellulitis, that's an infection, will be more red and swollen. But DVTs is mainly pain and swelling. Mm-hmm. And sometimes we can treat that with medication, which is great. Other times, if it's extensive, if it's causing a lot of problems like swelling from all the way down the leg and stuff, mm-hmm. we can go in and kind of break up that clot from actually inside the vein. Mm-hmm. So.
And you also treat aortic aneurysms.
We do.
Here.
We do. So 2 different ways.
Mm-hmm.
We do surgery, so if they have to be open, our vascular team, Dr. Colmia, can open and fix it. But he also, which we like, I guess it's easier. It's easier for me. It's easier for the patients too. It's not required surgery. But it is a vascular procedure where we go to the cath lab. Those grafts, so the aneurysm is kind of a bulging sac, typically due to high blood pressure, untreated. Mm-hmm. And if that aneurysm ruptures, unfortunately, patients don't survive, don't do well if it ruptured. So we really try hard to capture those beforehand. The grafts are tailor-made to the patient, to their actual anatomy and what their aneurysm looks like. And then in the cath lab, we go in and we put that graft in going through the groin, mm-hmm. and cover that graft and get it taken care of. So even if it did rupture, it wouldn't be harmful to the patient. Mm-hmm.
So after patients have had these major surgeries, how do you address them, like nutrition-wise? What are some recommendations on how they're supposed to eat?
So my patients, when they come in, typically with a heart attack or whatever, they didn't know they had heart problems.
Right.
Most people don't. It's all of a sudden they were fine last week and now we're not. Mm-hmm. So when you go at them trying to tell them they have to have this huge lifestyle change, and you use the word diet, a lot of times people don't like the word dieting, right? We fail at that. So we really talk about just lifestyle changes, picking one thing. For my heart patients, because that's what we mm-hmm. do, salt intake, because salt can affect a lot of things. So I was like, okay, I'm not telling you to stop putting salt on everything. Let's just limit it at first, so then where we can kind of work it out of our system to where we're not adding salt to everything. Because a lot of people, I've watched my family members and stuff, will sit at the dinner table and they haven't even ate their food yet, and they just start salting it. We got to stop that.
That's me.
Yeah, we got to stop that, because the food may not need salt, but that's what we need. And there's other things that we can use. There's seasonings and stuff that don't have salt in it. Mm-hmm. So the reason why salt is so bad is because salt stays in our body, and it kind of holds on to the water. And so we see a lot of swelling and everything. So the more swelling you have, the more fluid you're holding on to, your blood pressure will have a tendency to go higher. Your heart has to work harder because it doesn't have what it needs to get that out because our bodies are wanting to hold on to it. So salt is a really good thing. I always tell my patients, start with one thing a month to just try to change and to work on getting better. If you try everything all at once, they're going to fail. And I don't want my patients to feel like a failure. So salt first. Taking in enough fluids. Water, people are always like, well, I drink a 6-pack of pop and everything. It's great, but that doesn't have a lot of water in it. And people tell me, they're like, well, I don't like the taste of water and stuff. It doesn't necessarily have to be water. Anything that you use and mix with water. Teas, coffees, Kool-Aids, lemonades, whatever it is, especially in the summer months because we get dehydrated easier. Our blood gets thicker and it's kind of like turns into molasses. And when our blood gets thick, it gets sticky. And that's usually when we see our heart attacks happen, is in the summer months, people get a little bit dehydrated, their blood gets just sticky and everything, and it sticks to those walls, and we slow that flow down. So fluids, keeping hydrated is a good thing. And then just overall, a healthier lifestyle, healthier change, healthier diet. Limiting our fried foods. Using everything that we eat has cholesterol in it. That's what builds up in our vascular system. That's what clogs our arteries is cholesterol, good and bad. So if we can take some of those bad cholesterols away and change it with some good cholesterols, avocados, tomatoes, fish, stuff like that, vegetables and fruits, that will help and get rid of that. So if you're going to eat catfish, air fry it if you have to have the crunchy, if you have to have it, like that. Just don't eat a lot of fried catfish. Or bake it, there's different ways to still get what you want, just in a healthier way.
And you teach them that.
Yeah. So a lot of times we'll start with that and everything. You don't want to overload them all at once because they just had a major event. So we try to do it every day. We try to teach them something a little bit. Be like, hey, no salt, this is why, and everything. And so the next day I'm like, hey, no fried catfish today. So we try to make it fun, and we don't come all of them. You can't do this, you can't do this, you can't do this, and you can't do that, right? Their family's already telling them that. So they don't need me to tell them that. Yeah. So I try to say, okay, you want a salad? Great. Put some avocados on it because that has a healthier fats for you, and it'll help your cholesterol. So.
Can we talk a little bit about stress test?
Yeah, sure.
So what is a stress test, and when should one have a stress test?
So there are different types of stress tests. If you are a healthy adult, and let's say your job requires it, or you're an athlete, a professional athlete, and everything, typically what we do is we just have you run on a treadmill. We're looking for EKG changes. If you're having symptoms, or let's say you turn 50 and you have a family history and you're just really concerned. So that's when we would do like a stress test with what we call a nuclear scan, where we kind of inject you with a little radiopaque. It kind of follows the blood. We get scans of you. You lay flat. We get a scan of your heart. That's what we call the resting, what the blood flow is doing without stress. Then we put you on a treadmill, or we inject you with some medications to speed your heart up. That's the stress part of it. That's why it's called a stress test. We stress your heart out a little bit. We make your heart work. We like my preference is I like the treadmill better because that's more apt to what you're doing on a regular basis. So I like that one better. But some of our patients have bad knees, or they can't walk very well, or, getting on a treadmill, you could fall. So, if you have a lot of balance problems and stuff, but still want to know, then we do inject a little medication to speed the heart up. After that, once we get to a target heart rate, and it's different for every age. The older you are, the less heart rate I have to see if there's stress on it. The younger you are, the higher your heart rate's got to be. Then we we put you back on the same table. We rescan your heart and everything, and now that's called the stress imaging. So we're looking at that flow to see, did it change when your heart was under stress or not? We're also looking at your blood pressure and your EKG, and there's a lot of other stuff that we look at during that to kind of make that decision. Then you get a score, and the score is going to be, yes, the flow looks great, doesn't appear to be any concerns, or the flow is sluggish and we may need further testing or something like that. So if you're not having symptoms, you just want to know because of family history and stuff, a treadmill stress test plain or a calcium score. So we can do a CT scan of your heart to look and see if there's calcium buildup. So those are a couple different ways that people for who are low risk or there's not a lot of concern, but just a family history and they're just worried.
Right.
And then if you fall into that moderate risk, then I would say a stress test with images and everything. And then if we're high risk, then we usually just go straight to the heart cath. So, yeah.
Okay. Do you think genetics play a big...
Genetics plays a big role in it. I tell all my patients that because most of them, they'll come, they're like their dad had it, their grandma had it, their aunt has it and everything like that. I was like, you have it too. Like, so when I talk about genetics, someone who's come in with a heart attack and let's say it's the dad, I look at the kids and I'm like, this is genetics too. Like his dad had it, he has it. Chances are if you guys don't make some lifestyle changes, you may be right here
with
us. So, and I don't want my patients to get discouraged because a lot of them, they work out, they run, they lift weights and stuff. They eat healthy and then they come in and they've had a heart attack and they're like, I don't understand.
Yeah.
You can do everything right and genetics are still going to catch up to us. So what we try to do is be preventative and be like, okay, if you have a family history, let's modify our lifestyle, make sure we're walking. You don't have to run. You don't have to lift weights, but just make sure that you're staying active. Make sure you're staying hydrated. Make sure that you have a healthier diet. We're not eating fried foods every night and everything. You throw in some healthy foods. And then sometimes if I have patients who are very high risk, like both parents had open heart at a young age or something like that, a lot of times they'll go ahead and put them on a cholesterol medicine to try to help prevent that plaque buildup and everything.
Oh, wow. So it's huge.
It is.
Yeah.
Yeah, genetics play a big role in heart disease.
In heart disease.
Yeah.
So a carotid, when should they seek help? What is leading them to have to be placed on the table?
For a carotid. Okay.
Yeah.
So typically when somebody has a clogged artery, they're going to have symptoms. Usually we see this when people have strokes. Most people do not know that they have carotid artery disease until they've had a stroke or a TIA. So somebody comes in with stroke-like symptoms, weakness on one side, dizziness, headaches, different stuff like that, fluctuations in blood pressures, too high blood pressures, and then all of a sudden it drops too low of blood pressure. So those are some different signs and symptoms, but usually it's found incidental to something else. So they come in for a stroke, we scan them, and then the scan shows, hey, you have blockages in these arteries that supply the blood flow. So that will get you to a stent or we have to open you up. So if it's over a certain point, because people are like, oh, I have blockages in my arteries. Yes, and some of that you may have at 30% the rest of your life, and it doesn't cause no harm, no foul, nothing. If it's when it's flow limiting, when that means that vessel is occluded so much that flow is just not getting there. So think about it in ways of blood flow needs to flow through a straw, but it's now flowing through a coffee stirrer. Mm-hmm. That's when you see symptoms.
Okay, so...
Right. So what we do is we go in, Dr. Comia, who's our vascular surgeon, does our carotids here, goes in through the groin. We take the catheter just like it would for a heart, but we just bypass the heart and go up to the carotid arteries. We put in a little basket to kind of catch any plaque or whatever that may flake off during that, because this is a tinier vessel than in our legs and everything. Yeah. So kind of put a little basket there. Then we clean it out. We balloon it. We clean out your water pipes, so to speak. Rotor-rooter the vessel and everything. Sometimes we have to put a stent in there to hold it up. Take the balloon out, everything, and usually they go home in a day or so.
That's awesome.
If the blockage has been there for a long time, let's say that it's concrete, it's just hardened and we can't get the vessel open, then we do sometimes have to take them to surgery where we have to actually make the incision on the neck, open the vessel, clean it out that way, close the vessel, and then close the neck and stuff. And that's a little bit lengthier surgery. I mean, it's a bigger surgery and a little bit longer stay in the hospital.
So preferably it would be cath lab.
Yes, we definitely try cath lab. That's usually an outpatient. Like I said, they're usually here a day, 2 days.
Yeah.
Is usually the go for that. They come in, we do it, they go home, and everything. Yeah. So yeah, we do try that. But sometimes you get in there and people are hard headed, and sometimes they don't come in, or they ignore their symptoms. And then we go in there and it's like it's just hard calcium. It's a hard rock. We can't get our wire. We can't get a catheter across. Then if their concern is there's not enough blood flow from the other side, and they're having stroke symptoms and stuff and need to be opened up, then we'd go to surgery.
Yeah.
Yeah.
That's some good information you gave us
Yes.
today. Thank you
Yes.
so much
You're
for
welcome.
being with us today.
Thanks for having
So
me.
remember, you guys, if you're having chest pain, go get it checked out. Women, if you're just off, go get checked out. So
Thank you.